Okay. First of all, sorry about the late start, but I just could not look at screen. So, female reproductive system. Where is everybody else? Still with
I have no idea. I think I got the email like 5 minutes before class was supposed to start at 9:30. So I don't know if everyone else got it at like the same time, or maybe they just didn't check their email in time. I don't know.
Okay. All right. Yeah, I sent it 8 minutes before the start. I thought I can. No, let me not delay. And then it's like, well, no, I can't. I got to take medication. And hopefully I can at least have a late start. It's better than canceling.
Well, you know me, Professor. The female reproductive system is kind of my jam, so I'm here for this.
Yeah. Well, no, it is extensive. So I'll be surprised if people just don't check the announcement and not show up. But anyway, you know what? It's 10 o'clock now, so I'm going to go ahead and get started. So, female reproductive system. Okay, I think people are beginning to show up now. Let me start with the whiteboard here. I already have the recording. Okay, so female, I'm going to do the best I can. I have that tablet on a pillow. I think it should work out. Okay, so female reproductive system. How about that? The ink is pink. Ink is pink. Excuse me. So just like the orientation is very similar to male reproductive system, except that female reproductive system is pretty extensive. So we start with the gonads, which are the ovaries, left and right ovaries. Then we have, I thought I allowed everyone. Then we have ducts, just like in male reproductive system. And we have accessory organs. And then we have external genitalia. So stop doing that. Just give me that. So gonads, the ovaries, the ducts, uterine tubes, previously referred to as fallopian tubes, but that verbiage is no longer there. Uterine tubes. We got supportive structures. Sometimes one is referred as glands, which is uterus, the mammary glands. Then we have external genitalia. External genitalia this includes a number of structures, which is oftentimes the external genitalia in female will be referred to as vulva. And vulva involves mons pubis, the Labia Majora and Minora, Vaginal Orifice and Vagina, the clitoris. And there are some glands that are somewhat hidden, but along there would be the greater vestibule, greater vestibular gland and bulb of vestibule. Recall, we already know vestibule is an entryway space. Okay. So the external genitalia is pretty extensive. If we have time toward the end, I would like to go over some societal aspects of female circumcision. In a regular class, I always do female and male circumcision. Talk about some of the, notions that may not be right, etc. So overall, ovaries, uterine tubes, uterus, vulva. The only structure that I won't talk about is the mammary glands. That's just so specific that most allied health professionals won't have to know about those. If one or two of you have to know, it's pretty simple. It's just like, lobule and the lactiferous ducts, and basically the areola and the nipple. Okay, so we'll go over it in that order. Ovaries first, uterine tubes next, then uterus, and vulva, then the external genitalia. Okay. So let's look at some pictures here. Okay. Come on, bring it up. Gosh, just bring it up before. Thank you. Okay, can you see the ovary picture? Or do you just see all
still
of
them on the whiteboard?
Still the whiteboard. Okay, so
whiteboard.
let me stop share and start a new share here, right there. Okay. Oh, okay. So here is the ovary part of it. I don't have the whole picture. Again, somebody else took these pictures for me before campus closed. Ovaries. Basically, the ovaries are suspended in the abdominopelvic cavity. So if this is the abdominopelvic cavity, all right, it won't let me do that. I can only do it over the picture. This is the abdominopelvic cavity. Ovaries are suspended from the sides. So lateral aspects. So what suspends the ovary? This is an extension of the peritoneal membrane. Previously, it used to be called mesovarium. It's just an extension of the peritoneal membrane. And through this suspension, the extension, this is where all the blood vessels will be. I don't know how to change the ink. Let me see. Oh, this is where it is. So this is where all the blood vessels will be. Okay. So that extension of the peritoneal membrane, this is what we refer to as the suspensory ligament. Okay. So in the ovary model here, what you are looking at, this is falsely shown here, but they are trying to show the suspensory ligament, which I'll have a different picture. It's toward the edge. Okay. These are the blood vessels. So starting with, ovaries have a functional area, ovaries have germ layers, and ovaries have an inner area too. So basically, there are two layers of cell and tissue that do not contribute to the formation of the oocytes or support them in any way. Those are called the germ layers. Those germ layers are the external most, what you see here, this pink line that they're trying to show individual cells. This is germinal epithelium. Okay, there's this germinal epithelium. I'll have other pictures of this. You can see the same germinal epithelium right here. All of that. And there is a slightly clearer area below that. We'll be able to see that in a second. I'll show you another picture. Oh, tunica albuginea, the same tissue that we studied for testis, tunica albuginea. So right below germinal epithelium, this area from here to here. See this? Or in here, this. We'll look at a different picture in a second. Okay. This is what we refer to as tunica albuginea. Make sure that you can always referring to the layer as tunica albuginea of the ovary or ovarian tunica albuginea. We'll be able to see this in histology as well next week. Germinal epithelium, tunica albuginea. Besides these two, what else remains is ovarian stroma. So this and this together will be ovarian stroma. Just like kidneys have parenchyma, ovaries have ovarian stroma. Ovarian stroma is further divided into areas. Outer cortex. Cortex is where you see all these follicles, different follicles are. Ovarian cortex. And internally, where you see all the blood vessel. Right here, all the blood vessel. Inner zone, ovarian medulla. Ovarian cortex and ovarian medulla together constitute ovarian stroma. I'm going to write that in purple. Ovarian stroma. Okay, so this plus this ovarian stroma, which is further divided into ovarian cortex and ovarian medulla. I'll go over some of the follicles here, then we'll look at the follicles, slightly enlarged follicles in a second. So what do we find in the ovarian cortex? We find follicles of different sizes. Follicles are basically like tiny, think of them tiny blisters with oocytes within them. These follicles at puberty, about 19 of these follicles that until puberty stay small in clusters. At puberty, they start enlarging, about 19 or 20 of them every month. When these smaller follicles enlarge, they gradually become slightly larger. Then there will be multi-layer of cells with the oocyte in the middle. And then they become very large. And then it ruptures and the oocyte is released. That is what ovulation. So we can see some of this. After the ovulation, the follicle shrinks a little bit, but still continues to produce hormone for 2 weeks. In that 2 weeks, so the basic foundational idea here is in that 2 weeks, if fertilization and implantation has not happened. So it must happen within those 2 weeks. If fertilization and, more importantly, implantation has not happened in those 2 weeks, then the follicle will completely shrink, stop producing hormone, and become a scar tissue-like structure. So, name of some of those follicles. The tiny cluster of follicles that start growing, which has nothing but the oocyte and an external layer, refer to those as primordial follicles. This is what we are born with. This is what female infants are born with. Primordial follicles. These are in cluster, the smallest size. At puberty, these primordial follicles, 19 or 20 of them, start enlarging. About half of them will perish. Other half will become this primary follicle, and we'll look at, some better one in a second. Primary follicle. Half of the primary follicle, or few of the primary follicle, will not make it to the next stage. But those that do, they become more enlarged, larger, and they will have multiple layers of cells. We can look at the follicles in histology much better than the model, but this is still good to have an idea. This is what we refer to as secondary follicle. So this is secondary follicle. One of them will enlarge before others, and right when the primary follicles form, these will start producing estrogen, not as much progesterone, but estrogen and progesterone, mostly estrogen. One of them will outgrow the others and become a very large follicle. This is what you will call this Graphene follicle. The rest of them will go through atresia. See, this one shows an atresic follicle, how it's shrinking, the oocyte is dissolving. So ovarian, the germ layers, germinal epithelium, tunica albuginea below that, ovarian cortex, ovarian medulla, together ovarian stroma. Medulla has blood vessel. Cortex has different follicles. We can see the primordial follicle, primary follicle, secondary follicle here.
I have a question.
Yes.
But for the primary follicle and the secondary follicle, so are those like, is the one on top, like that's the whole secondary, and the one below, that's the whole primary? Like, does that make sense?
Yeah.
Okay.
You mean this one, right?
Yeah, so the top, that's the whole thing. It's the whole secondary follicle.
All of this, what I'm tracing right here, is secondary, yes.
Okay. And then
And
I have one more
this
question.
below is the primary.
And then can you see the ovarian hilus on here?
Ovarian hilus not here. I'll show you that. I'll show you that in a second. Okay, so let's look at another picture here. Let's see what I want to look at now. Okay, this is actually a nice one. Okay. Right there, that's the whole model. So as you can see, let me change the color so that it's a little
I can't see it.
I'm unable to see. I'm not sure.
Oh, yeah, sorry, I forgot. Yes, I have to start a new share for each picture. Give me the zoom control. Just a sec. Let me move this. Huh? Oh, someone has a nice pond picture there.
Thank you.
Okay, should be able to see now. Okay.
Yes.
Yeah, I sometimes forget. I have to stop the previous share, and initially before the update, it let me go through the pictures. Once I share a screen with all the pictures, it allowed me to do that share continuously, but now seems like it doesn't. To stop and start, and sometimes I'm forgetting. Anyway, so we can see the entire ovary here. So this would be the suspensory ligament right there. Suspensory ligament. This zone is the ovarian hilus right here, because the ovaries are suspended like that. Basically, imagine that's the abdominopelvic cavity from here to here. That person's head will be here. You know what I'm saying? So that's the right side of the abdominopelvic cavity. That's the left side. This ovary is suspended. This is ovarian hilus.
So it's like that area
Yes,
between the two red
it's
lines.
that area, yes. The area where the suspensory ligament enters the ovary. This model shows as if the suspensory ligament is all throughout. It's not. The suspensory ligament enters, or rather suspends, the ovary through the edge corner of the ovary. And that's where the blood vessels are entering. This is the ovarian hilus. Okay, so this side, what you see, this is also another ligament. This is known as ovary. What is this? Knock me out of that. Ovarian ligament. This is ovarian ligament. The uterus will be here. You'll see later. So that's the ovarian ligament. So we can see again here. Change the color so that is more visible. This will be what? Which zone? Blood vessel.
That would be the ovarian medulla.
Ovarian medulla, yes. This area, basically from here to here, is ovarian cortex. I'm not writing ovarian here, but in your answer you have to write that. I'm just writing cortex for lack of space. In that ovarian well, beyond the ovarian cortex, you see the germinal epithelium right there. And you see the tunica albuginea of the ovary, or ovarian tunica albuginea. See, there's a little clear area, just a little. We can see this better in histology, but let's still try to identify this here.
Is it the lighter line that runs parallel to the germinal?
Exactly, the lighter line.
Okay, thank you.
So right there, ovarian tunica albuginea. Let's look at the follicles here. Primordial follicles. You have the lab manual, you have the spelling. Primordial follicle. I'm going to abbreviate for lack of space to write everything. Primordial follicles, when they start growing, they become primary follicle. Primary, this is a primary. That's an atresia follicle, that's shrinking. Oocyte in the middle, row of cell around, single row of cell, that's how you identify. Primary follicles are standalone, they are larger, they have oocyte and one row of cell. For secondary follicles, oocyte in the middle, they're even larger. Oocyte in the middle, and you can see 1 and 2 row of cells. One row of cell around the oocyte, another row of cell around the edge. Again, these cells are much better visible in histology. The model is good for reference still. Secondary follicle. Eventually, out of the 5 or 6 secondary follicle that might be forming, one of them outgrows everyone else, and that's the only one that survives. And that becomes very large right here. This is what we call graphene. That's another thing, to keep changing color. Graphene follicle. See how much larger that is? In histology, next week, we'll talk about the follicular antrum. But basically what this is filled with, the space is filled with fluid. The space is follicular antrum. Filled with fluid, that's estrogen, progesterone, so much that the oocyte, you don't see it, the oocyte is around the edge somewhere. This is what will burst. Burst meaning rupture. And then the oocyte will ooze out with the fluid on the surface of the ovary. Okay. So a menstrual cycle composes of this gradual enlargement of the follicles, eventually in humans, eventually formation of a single graphene follicle, which will ovulate, burst and release the oocyte, typically halfway into the menstrual cycle. For the second half, the 2 weeks, menstrual cycle is studied as 28 days. For the second half of the menstrual cycle, this graphene follicle is going to be staying as a structure that's filled with a yellow fluid, and it will keep secreting hormone. It will keep secreting progesterone. Okay? As long as this follicle stays here, you no longer you call it follicle because the oocyte is not there. As long as the structure is there, that long the uterine lining will keep developing. This is called corpus. Change color again. Corpus luteum. This is corpus luteum. In 2 weeks, if there is implantation, which obviously means fertilization, then the zygote, basically after the fertilization, the zygote pretty much will secrete a hormone to keep this corpus luteum in place. It's called the rescue the corpus luteum. We'll talk about it in physiology, but a hormone known as human chorionic gonadotropin, HCG. HCG is secreted from pretty early stage of the post-fertilization development of the embryonic development. But the level of HCG that can rescue the corpus luteum is not reached until that embryo is an implantable stage. You know what I'm saying? So the zygote goes through, 2 cell, 4 cell, 8 cell, then 16 cell, then 32 cells, all the way to 64 cell, a ball of cell. And while the embryo enlarges and has more cell, the embryo also secretes more and more HCG. But the HCG level has to be a certain level for the corpus luteum to be rescued and maintained. And that level is not reached until the embryo has reached what we call an implantable stage. Don't worry about the name, it's called blastocyst. So within the 2 weeks after the ovulation, the embryo should or must reach the blastocyst stage. If it has not, then the corpus luteum after 2 weeks will just vanish. It will just completely shrink. The entire hormonal support that was given to the uterus will abruptly stop, and everything that was growing in the uterus will come to a screeching halt, and the cells, the blood vessel, etc. that were formed will basically die. Cells flood, first the blood vessels will rupture, cells will die from hypoxia, and dead cell and blood, etc., will then be sloughed off by the uterus. That is menstrual blood flow.
So I just have a quick question. I just want to make sure I have this clear. So in the follicular phase of the menstrual cycle, it goes primary, secondary, Grapheene,
Yes.
then ovulation, and then the luteal phase is just the Corpus Luteum, correct?
Exactly.
Okay.
Yeah,
Right,
those
thank you.
stages are named so that you know that what's going on in the ovary.
I
And
figured as much. I just wanted to make sure I was clear on it.
Good, good. And the uterine stages also correspond to that. You know, in uterine stage, the first half is pre-ovulatory, or you can call it, proliferative secretory, but I just call them pre-ovulatory, post-ovulatory. Pre-ovulatory phase, right after the 5 days of bleeding, the uterus is, okay, let's start growing under estrogen. That's what follicles secrete. After ovulation, corpus luteum secretes more progesterone, not as much estrogen. And progesterone is a massive build hormone for the uterus. So maximal uterine building happens in the last 2 weeks. And that's why once that progesterone is gone, and it will be gone in just like that, overnight the corpus luteum shrinks and no more hormone coming through. And all the blood vessels that were growing, etc., all of a sudden, for the lack of the hormone, the wall of the blood vessels dry up, the blood vessels rupture, and the cells that were dependent on those vessels, which were newly formed, layers and layers of cells in the uterus, they all die from hypoxia. And the menstrual flow starts. Next month, start it all over again. The uterus is anticipating there will be an implantation this month. The ovary is anticipating there will be fertilization this month. And basically, the whole process starts all over again. Okay. Any other question about the structure, etc. here? Okay.
I have a question. Well, actually, I'm just going to wait until we get to the actual uterus. So
okay.
I'll wait.
Yes. Okay. So let me start another picture here. Okay, so we are looking at, so I want to show you the Graphene follicle. Can you guys see the ovary?
I just see all of the pictures.
Oh gosh, it just won't let me do that. Okay, fine. All right, so again, this is a little clearer, but it shows you the Graphene follicle. You want to also see how the primary and the trizig follicles are different. See that? The primary follicle has a single row of cells. You can see the secondary follicle has 2 rows of cells. And that little tiny white space between the 2 rows, that's where the follicular antrum is forming. Then deposited fluid here will expand that, and this becomes this. Graphene follicle. This is the secondary oocyte. There are groups of rows of cells along the secondary oocyte that will also be ovulated. You can see the germinal epithelium really clear. You can see the tunica albuginea also fairly clearly. See that? Tunica albuginea, the lighter color. Okay. You can see the corpus luteum. You can see primordial follicles here.
Can anybody see the mouse the teacher is showing?
I can't see it.
Nope.
No.
No.
You see the arrow?
No.
No.
So this now, I'm moving it between the graphene and corpus luteum. You don't see that?
No, we can't see that. We can see when you draw.
Okay, all right. So this is the graphene. follicle. This is the, what is this? What is this? This row of
Which part are you
cells.
looking at? Oh, the
Germi-
layer epithelium.
germinal epithelium, yes. And then this here, I'm going to just put dot because I don't want to obscure that. This is the
That's the
tunica
albuginea.
ovarian. Yes, always say ovarian tunica albuginea because testis also has tunica albuginea. Okay. Now this is corpus luteum. See, it doesn't have any oocyte and it looks yellow. This corpus luteum really enlarges and stays throughout the pregnancy if implantation has happened, and that's called corpus luteum of pregnancy. It's the job of this corpus luteum to keep the uterus calm all throughout the pregnancy, because the uterus basically will try to shed off and mount a response against the invading embryo. For the uterus is an invading organism. It will mount a response, but that response is not allowed because of the corpus luteum. So, and I'm kind of speaking ahead for the menstrual cycle, but throughout pregnancy, those that are called slightly at risk pregnancy are the ones whose progesterone levels are lower than the estrogen, or the estrogen level is a little higher than normal. Throughout pregnancy, first and second trimester, progesterone level is supposed to be much higher than estrogen, because progesterone's effect on the uterus is that it calms the uterus, it inhibits immune response, it inhibits uterine contraction. From third trimester, halfway almost into the third trimester is when progesterone starts dropping, estrogen starts coming in because of different hormonal interaction. So the uterine contractions that women feel toward, as closer to they get toward the childbirth, the intensity of the contraction and the frequency will increase. That's estrogen. If that same contraction happened from the first trimester onward, then there will be miscarriage. So everything, all the hormonal support is done according to what is needed. So corpus luteum's main job is to provide progesterone. So that's what it does. Throughout pregnancy, it has the same function to provide progesterone to make sure the uterus is not trying to shed off or slough off the embryo. Later on, the embryo becomes fetus and it becomes stable, but still. So all throughout the first two trimesters, typically the corpus luteum will keep secreting more progesterone, less estrogen. That's what this is. But this is just a regular corpus luteum. The corpus luteum pregnancy is huge.
So you just said that the corpus luteum in pregnancy is huge. So when they do ultrasounds during pregnancy and they mention they're seeing a quote unquote cyst on the ovary, are they actually seeing the corpus luteum enlarged?
No.
Okay.
Cyst is this. These are cysts.
Okay.
Yeah, cysts are basically, for whatever reason, cysts are basically the cells that are supposed to be within a follicle without a secondary oocyte. Sometimes it's previously like a secondary follicle that is supposed to have gone atresia, or a Graphene follicle that's supposed to have gone completely atresia. Later on, can end up being a cyst. But cysts are basically cells that can produce hormone, almost like a follicle, but they are encased by a membrane most of the time. And the cells continue to produce excess estrogen, progesterone, and more than that, androgens. That's what cysts are. So these are cysts.
So those are the cells like during endometriosis. Does that occur within the lining of the ovary or just outside of the uterus?
Endometriosis is for uterus.
Okay.
Endometriosis is an abnormal thickening of the endometrium as a result of excess hormone, or sometimes as a result of STD. Chlamydia infection gives rise to endometriosis, which is of course, less common. Most of the time, young females or not so young females, it happens mostly in younger females. They're diagnosed with endometriosis because of abnormal hormonal imbalance, excess hormone. Okay, so we can also see the not corpus, ovarian medulla here and ovarian cortex. Okay. What does this mean? Cancel what? Oh, okay, never mind. Cancel or not, doesn't matter. Let me show you the corpus albicans. Oh, right there. This picture is a little hazy. Okay, right there. This is as good as any. A little bit hazy, but I want to show you the corpus albicans. So corpus luteum, after it shrinks, basically, if there is no implantation, corpus luteum vanishes. Doesn't vanish, rather it shrinks and becomes a scar tissue-like structure. We refer to that as corpus albicans. So here, this is corpus albicans. This one. Okay. Again, we can see slightly enlarged secondary follicle. We can see primary follicle. This you can ignore, is an atrasic follicle, meaning this is a primary follicle that did not make it to the secondary. Half of them don't. We can see the germinal epithelium. We can see the ovarian tunica albuginea, ovarian medulla. And you can see the Graphene Follicle too. Okay. All right, so that's for the ovary. Let's look at the uterus and uterine ligaments and uterine tube. Let me see which one I want to bring up. Okay, this is good. Okay, yes, and then I have to start a share. All right, where is that picture? Yes, this. Can you see the uterine ligament and uterus?
No.
We're just seeing all your photos again.
New share. Okay, now it's bringing it up. Sometimes it won't bring it up. Actually, you know what? Let me do this. Share. Okay. How do I rotate this? Doesn't know. Calligraphy pen. I don't want to do calligraphy. If I wanted to do calligraphy, I'll be moving to China. Sorry, I'm just kind of talking to myself. What is this? Talk to talk. I have no idea what that means. All right.
You can try clicking on it. I don't know what kind of mouse you have, but you can try clicking on it, left or right mouse button, and see if that helps.
No. I mean, if I'm not sharing it, oh, it's giving me blue dots where I'm clicking now. If I'm not sharing it, I can rotate it. But once I start sharing, it won't let me rotate. Anyway, do you guys, you can see all the parts, right?
Yes.
So let me just go over this and then I'll try and rotate it and then bring it something up again. So basically, we are looking at the ovary, the uterus, the uterine tube.
We don't see what you're showing.
Oh yes, ovary. At least you can laugh and make fun of things. The ovaries, sectioned ovary, non-sectioned ovary, the uterus. These are the uterine tubes, full uterine tubes, sectioned uterine tube. This is the vagina. So vagina, uterus, uterine tube. You can see ovary, ovary. Okay, so let's go over the ligaments. Let's look at this ovary here. So what you are seeing here at this end, basically again, your abdominopelvic cavity will be here. This is where the head will be. Okay, that's the head. Sorry, you have to imagine the head. Anyway, I'm just going to laugh at anything I can. Okay, so this is the lateral edge of the abdominopelvic cavity. So this is what I meant by the ovaries are suspended through here, see? So this is the suspensory ligament that we looked at earlier. This here is the suspensory ligament. You can see how it suspends the ovary. Suspensory ligament. Here also suspensory ligament. Then this ligament here, let me change the color. This is a nice shade of blue. This ligament here, this from ovary to uterus, or from here, ovary to uterus, we refer to this as ovarian ligament. Okay. Then the uterine tube, let's go over the different parts of the uterine tube. So I'm going to erase that suspensory ligament so that the uterine tube is visible. Okay, right there. I'll draw again. So uterine tube, this finger-like projections here, these are what we refer to as fimbriae. See how they're finger-like? Or this side also you can see how they are finger-like. Fimbriae. This is also fimbriae. Let me erase the ovarian ligament also. No, not all ink. Oh, come on now. No, I don't want to erase all ink. I just want to erase this. Stupid computer. I'm going to erase this. Okay. Yes, please. Not so thick. A little thinner. Okay, good. So, fimbriae, finger-like projection. Okay, fimbriae. Then, from the part that the fimbriae are attached to, this wider, I won't say wider, but more like funnel-like. See how that's the funnel-like part? Here you can see how it's, go to hell. Sorry. As it is, I'm in pain and all these stupid things. So here, the funnel-like part. See that? Refer to that as infundibulum. Let me change the color so that we have a different color. Infundibulum, right there. Infundibulum, right here.
And would that be an area or structure? Considering
This could be this could be parts.
Okay.
Parts,
So
areas. I won't call them areas. These are parts.
So like the fimbriae, that's a part, right?
Yes, all of these are parts. Basically, these are segments of the whole structures.
And the whole structure would be like the uterus.
Uterine tube.
Uterine tube. Okay. There we go.
Tube. Okay. Okay, so fimbriae, infundibulum. Then the upper 2/3, where it's wider from here to here. See that? It's wider here. Same thing here. From here. No, don't give me those. What is this? Whatever. From here. Anyway, this is here to here and here to here. Okay. This is what we refer to as ampulla of the uterine tube. Don't just call it ampulla because ampulla is such a generic term.
And
Remember,
that's where fertilization occurs, correct?
That's where fertilization occurs, yes. Ampulla meaning wider neck. Ampulla of Vetter. Same thing, ampulla of uterine tube. Here to here. The lower, actually this would probably up at 2/3, so this probably would go up to here. Then the lower 1/3 where it's constricted. What color have we not used before? Turquoise. The lower 1/3 here to here. See how it's constricted? Here to here. This is what we refer to as isthmus of the uterine tube. Okay, gosh. I'm going to write it in a different color. Isthmus of uterine tube. Okay, from here to here, here to here. Isthmus, anatomically, when a part of a structure is constricted, you call that isthmus. So here you have to say isthmus of uterine tube because the uterus itself has an isthmus too, where it gets constricted, right there. You can call that uterine isthmus. We'll talk about that in a second. So always say you write as isthmus of uterine tube. Okay. So uterine tube has 4 parts: fimbriae, finger-like, infundibulum, funnel-like, infundibulum, funnel-like, ampulla, upper wider 2/3, isthmus, lower constricted 1/3. Okay. Let's look at the function of each, what each part does. When the ovary, notice how the fimbriae are so close to the ovary. When the Graphene follicle ovulates, let's say that's a Graphene follicle. Graphene follicles are pretty large for human. It ovulates and the secondary oocyte just oozes out with the fluid. Fimbriae here will bend and keep sweeping. I wish I could show you the sweeping motion, kind of like if you spread your fingers and go, you know, come here type of movement. These will sweep, these fingers will sweep. When they will sweep the liquid, basically the antral fluid, and hopefully the secondary oocyte into the fimbria. 99.9% of the time they will be able to do that. Once in a while the fimbria fails, meaning if the Graphene follicle is, let's say, on the other side of the ovary and the fimbria just can't reach, or maybe it's too close to the ovarian ligament, it's no telling where the Graphene follicle will be. The fimbria fails to catch the oocyte in time. Well, no harm done. The oocyte will fall into the abdominopelvic cavity and perish. Once in a while, through the lifetime, a woman typically will miss period once in a while without any hormonal imbalance. If the hormonal, hormones are in balance, and still a woman misses period once in a while, literally means that likely the fimbria did not catch the secondary oocyte. It fell on the abdominopelvic cavity.
I have a question.
Yes.
So usually when I speak with most women or just people that are on birth control that take the shot, they say that after 3 months they don't have a period. So is that just the cause of the graphene not able to be swept from the fimbriae?
No. The
Or
birth
do I have to
control
do with hormones?
That's the birth control hormones.
Okay.
Birth control, basically what it does. Also, those that say that they don't have period, they are all on estrogen or estradiol birth control. There are 2 types of birth control. I'll talk about it in physiology in details. Probably.
Okay, no worries.
But there are 2 forms. One is manipulating the estrogen, one is manipulating the progesterone. Typically, they are not called progesterone or estrogen. They are actually in birth control language. That typically estradiol and progestin or pregnenolone. So basically, progestin and estradiol, these have 2 different ways. Progestin-based birth control pills are safer because it allows you to ovulate. It allows you to have your periods, thereby prevents an abnormal thickening of the endometrial lining. But at the same time, it doesn't render the uterus hospitable. So basically, you can ovulate, you can have, fertilized, zygote, etc., which won't be able to implant. Now, some individuals, sadly, I would say a lot of individuals are brainwashed by religious teaching that, every single zygote is a human life, or whatever they choose to call. I'm not generalizing, and nor am I criticizing these individuals, but I am criticizing the brainwashing without any biological basis at all. So they opt to have estradiol-based control. Estradiol-based birth control, basically it stops ovulation, it stops the follicular growth. So you don't have periods. No ovulation, no periods, so the endometrial lining can get thicker. These are the ones that can have endometriosis later. These are the women that will have difficulty with getting pregnant once they get off the birth control, because these are estradiol-based. And that's what estradiol-based birth control pills do, or any other kind of shot. That's what they do. They prevent follicular development and ovulation. Progestin-based devices, control pills, etc., what they do not prevent ovulation, but they do prevent implantation, which is a much safer biological form of birth control. However, naturally through the life of a woman, it will happen many times for every sexually active female that the fertilization will come late and the embryo will form. It won't be able to implant, and it will be washed with the menstrual flow. That's just biology. So those that feel that, oh, by using, I don't know why I'm drawing anything here. By using estradiol-based birth control measures, I'm actually saving every single possible embryo. Well, no. Once you get off that estradiol-based, once you start having periods, as long as you are sexually active, naturally, there are many late fertilizations that happen. That's just, like I said, that's just biology. That's how it works. So no, we can't save every single zygote. And keeping the embryos, because they are possible human lives, and just freezing the embryos for eternity, those are very early embryo. They are not sentient. No matter what, whoever says what, they are not sentient. Freezing them for eternity so that the potential human lives, which are not potential anymore because they're frozen, very early embryos, they lose their potential, but not use them for any kind of research. Most of the time, that research is cancer research against childhood cancer. And let the actual children who are here and are suffering from childhood cancer, let them die, but let's keep the embryo frozen for eternity. These are very non-biological thinking. They have no scientific basis. So just so that you know, okay. Sorry, I got a little carried away, as you can tell. Anyway, so those are the parts of the uterine tube. So fimbriae sweeps the secondary oocyte within. And then the peristalsis starts, the same movement that we saw in GI tract. Peristalsis starts, the secondary oocyte travels into the ampulla, then, into the infundibulum, then into the ampulla. Chances are this is where the fertilization will happen. So by the time the zygote passes through the isthmus and lands in the uterus in 2 or 3 days, less than 7 days, that's what it has, it will be in an implantable stage. Okay. If within 7 days, the 7 days of staying within the uterus, if the embryo is not in an implantable stage, then 7 days is also an ideal extension. Normally, 3 days, maybe 4 days, that's what typically the embryo has. If the embryo fails to implant itself within, less than 7 days, the menstrual flow is coming. Okay. I would also like to talk about the ectopic pregnancy here, because this is where we can do whatever we can talk about. I'm going to erase all ink. Any question about what we have marked up so far? All right, so I'm going to erase all ink and draw again. Ectopic pregnancy. What happens in ectopic pregnancy? Ectopic pregnancy typically happens for females, 2 groups of females. One, more rare, will be those whose isthmus is extremely narrow or at a weird angle. So instead of the straight isthmus, which is most female would have, some people would have an isthmus that goes like this. It connects like this, giving rise to a weird angle. That makes it difficult for the embryo to pass through. So the embryo gets stuck here and it tries to implant itself here. And for a few weeks it can, but the uterine tube is not designed to expand further. If the uterine tube ruptures and is caught well in time, then of course the embryo cannot be saved, but the female can be. If the uterine tube ruptures and the female does not know what kind of pain it is and where is this pain coming from, in many parts of the world, women will just continue on with their lives, especially, in zones that have poverty, the women have to work. So, what all kinds of pains, and this also is added to that pain, and who knows what, maybe a bed rest sometimes, just rest, this will get better. Ignorance, mostly lack of medical knowledge or access to knowledge, is unfortunate. And if the inflammation starts here, then typically you have already started a case of peritonitis, and plus the shock of the uterine tube, which will further rupture. Basically, then it's lethal for the embryo, of course, and for the mother too. That's the more rare situation. Most of the time, what happens for ectopic pregnancy, that an embryo starts to implant itself in the uterus, and the uterus is not hospitable, it's inhospitable, inconducive So it resists and it tries to shake the embryo off. And after shaking it, it regurgitates it into the uterine tube. So the embryo gets regurgitated here, and then it tries to implant itself here. One way or the other, ectopic pregnancy is a fatal condition if it's not removed, embryo is not removed in time. Okay. Any question about this? I will come back to this model again. I would like to show you the broad ligament, and then we'll go over the, actually, you know what, we are right here. Let me talk about the different parts of the uterus, then I'll show you the ligament. So since we are here, let's talk about the different parts of the uterus. Okay, so uterus itself has 4 parts. Uterine fundus, the bulge right here, see? This is why you have to refer to gastric fundus. This is, what can I write right there? Uterine fundus. This is the superior part, uterine fundus. Then this will be uterine body. Some say body of the uterus, just like gastric body, uterine body or body of the uterus. Then this narrow constricted zone right there, see that? Right where? It's constricted here and here. This is what we refer to as uterine isthmus. The TH is silent. Uterine isthmus. And what stays below that uterine isthmus? This part. This is the cervix. Notice that we are not calling it uterine cervix. Uterine fundus, uterine body, uterine isthmus, and instead of calling it uterine cervix, we are calling this cervix. Cervix is almost given different name because this is the part that's accessible. Lots of diagnostics are done based on the cervix. So cervix is treated almost as if it's an independent part of the uterus. It's not. It's extension of the uterus. It is part of the uterus. But it's just, given different name. Who knows why? Well, actually, I can see why for the diagnostics. So those are the different parts. Question about those. And I'm going to go over the internal parts.
Just a real quick question. In the cervix, is that just a mucus plug that's in there?
Yeah, that's a cervical plug.
Okay.
Yeah.
I wasn't sure why it was white. I wasn't sure if that was like a
yeah,
or that we need to know. Okay, thank you.
I have,
Okay.
what's the white thing in the uterine body? It's like the little white circle.
Oh, this is like an implanting embryo.
Oh, okay. Thank you.
So I'm going to erase this. Erase all ink. Yes. What do you think? All right, so I have to have something bright so that it stands out. So the inner part. First of all, this space within the uterus, this is the I said orange. Uterine cavity. Right there. Uterine cavity. Okay. The space within the cervix, which is right now, it's plugged by the cervical plug. In pregnancy, typically there is a cervical plug that forms. This is cervical canal. Okay. And because cervical canal and cervix is treated like as if it's a standalone part. The opening of the cervical canal into the uterine cavity and the opening of the cervical canal into the vagina are given names too. This opening into the uterine cavity, notice that is almost like a straight line. You draw a straight line through the cervix. This is the cervix, constricted part right there. If you draw a straight line through the cervix, it will pierce through that opening. Opening of the cervical canal into the uterine cavity. This opening is referred to as internal os. The opening, let me use a different color here now. Yes, now give me purple. The opening of the cervical canal into the vagina, this is what we refer to as external os. Okay, internal os, external os. Cervical canal, right there, uterine cavity. These are the inner spaces. Got that? Okay, so I'm going to erase these inks and now go over the wall of the uterus. Now let's take a look at the uterus itself here, the structure of the uterus. The uterus is made of 3 layers of tissue. The outer one right there, this, refer to this as the perimetrium. Perimetrium right there. Okay. The middle muscle layer. No, that's too close. Read something. The middle muscle layer, right there, here. That's the muscle layer. This is the muscle layer. This is the muscle layer. Okay. This is called myo, as we know, myo meaning muscle. Myometrium. Okay, so perimetrium, myometrium, and this dark layer here, this is the inner layer of the uterus. We refer to this as endometrium. In histology, we'll look at endometrium actually has 2 layers. An inner part of the endometrium, if we are to draw that here, what I'm drawing, the very inner part of the endometrium. This is referred to as stratum functionalis. The outer part of the endometrium, because endometrium is basically 2 sublayers. The outer part of the endometrium, what I'm drawing in green here, this is referred to as stratum basalis. In menstrual flow, stratum basalis stays. Stratum functionalis is shaved off or sloughed off. So same here. See the inner part, inner sublayer, stratum basalis, and stratum functionalis. since we are talking about uterus, I'll talk a little bit about the implantation and at-risk pregnancy. The safest place and the natural place for implantation is here, fundus. Okay. What the endometrium has, why we need that endometrium and why do we even build that endometrium, is because the endometrium has what we call endometrial glands, which I'm trying to just draw with dotted light green dot. The entire endometrium is full of endometrial glands. These are critical in inhibiting an immune response by the uterus to the invading embryo. So basically,
real quick, are those glands on both the stratum functionalis and the stratum basilis?
yes, basilis and functionalis. But when the functionalis develops, those glands become really elongated and spiraling.
Thank you.
Yeah. So basically, the few days that I was talking about, the embryo has to reach an implantable state. The embryo in the uterine cavity basically stays a few days and it kind of bounces against the walls. And where it can stick, which will be most of the time wherever there is the greatest number of endometrial glands, that's where the embryo will stick. That's where it will release digestive enzyme, starts digesting the layer and start incorporating itself. So when it comes to uterus's perspective that this is an invading organism. So most normal full-term, non-at-risk natural pregnancies are basically, this is where the implantation will be. The next area is along the body where they are showing here. Sometimes it's the body that has, some women, body has greater endometrial glands than the fundus does. This is still okay. It's still in the body, body can expand. If the implantation is near the cervix here, these are the pregnancies that will require C-section because it's too close to the isthmus and this part of the uterus is not going to be able to expand as much. So the childbirth itself is going to be troublesome. The embryo will get stuck. So most C-sections will be done for implantation that was done that happened near the cervix. This is not the least desirable place for implantation. But for some women, that's where the endometrial glands are. So that's where the embryo goes. So many variables for pregnancy, for fertilization first, then implantation, then a successful pregnancy. I mean, it's almost, I kind of feel like it's a miracle that there are so many humans on the earth, considering there's so many barriers to that. Anyway, so do we have all the parts here of the uterus, uterine tube?
I have a quick question about the layers here. Okay. So we're just talking about where the zygote would implant. Mm-hmm. But what about
it's embryo at this point?
Okay.
It's not a zygote. No.
Okay. So where the embryo would implant. So would the placenta itself, would it go through to the endometrium, to the myometrium? How deep does the implantation actually reach after the embryo?
Good question. After the embryo implants itself through the endometrium, it will border at the endometrium and part of it will go into the myometrium. The way the placenta works is that the placenta sends, not placenta, the fetus at this point is a fetus. The fetus basically sends extension of its tissue. Okay. The maternal blood vessels, because this uterine tissue is going to be, around here is going to be almost, partly dissolved, so to speak. The maternal blood vessels will form sinuses around them. It's a different color. So the maternal blood vessels will form sinuses around them. So placenta is going to be part of the maternal tissue, which is borderline endometrium, myometrium, not, I'm kind of drawing it here, it's too large. It's not the entire myometrium, but it's borderlining myometrium. The embryo will go up to here, not all the way deep into myometrium. If that happens, then it will be very hard to dislodge. However, the extensions of the fetal tissue, will lodge into the myometrium. That's what placenta is. So when we say placenta, what is placenta? Placenta is basically the fetal tissue extension that lodges into the myometrium and the maternal tissue that forms blood vessels and the sinuses around it. So basically what the placenta would look like, this is the fetal extension will be, and the maternal blood vessel will form sinuses around them. So there will be pooling of blood right here around those extensions. And that's where the oxygen, nutrient, etc. will diffuse into this. And the fetal blood vessels will form into those extensions and then supply the fetus. All of this will basically become the fetal umbilical cord. So when it comes time for childbirth, when the uterus goes through violent, pretty intense contraction, what it's dislodging is this extension and the whole embryonic sac, the embryonic germ layers, all of that, and this part, the placenta. And the bleeding that happens with childbirth is basically because there are sinuses here. Sinuses are basically, space that are filled with blood within which this placental tissue is dipped into. But it won't go all the way into the myometrium. The fetus itself won't go all the way into the myometrium. However, the extensions will definitely go deep into the myometrium. This is why the risk is, although it's pretty secure, if there is uterine trauma, then people can still miscarry. It's not completely fused with the myometrial tissue. It's lodged into the myometrial tissue. Mammalian fetuses, including the great apes, which, basically we are descendants of great ape, is still the most secure. The human fetus, along with the other primate, they go as deeper than probably many other animals. But it's not completely encircled in the myometrium. If it did, then nothing can dislodge that fetus. But the extensions go deep into the myometrium.
So if it went too deep into the myometrium, is that where you would see like placenta, creta? And then I would assume if it went into the perimetrium, that's where you see percreta, just judging that.
Yeah,
okay.
That's why those are anomalies. They are not a routine phenomenon. Okay, so while we are at it, I'll show you two of the fornices. Okay. So we went over the different parts of the uterus, the inner spaces, etc. Remember the internal and external os are structures. They are not spaces. Cervical canal is space, uterine cavity is space. These are not, these are actual structures. Okay. When uterus, then I'll show you the broad ligament in a second. When the uterus protrudes into the vagina, so this is the vagina. You can see the vaginal rugae. These are the vaginal rugae. When the, I would say uterus rather cervix, the cervix protrudes into the vagina, it creates arch. See, this is an arch. The vaginal wall and the cervical protrusion forms arches. These arches are referred to as fornices, plural fornices, individual fornix. I'm going to erase all ink. And
Are
then
they on the list?
start
Okay.
over. Sorry, what?
I can't find them in the list of manuals.
So fornices. There is a posterior fornix, which would be here. We have another model, I'll show you that. Here you can see the lateral fornices, this and this together. Lateral fornices. Make sure that you are using the plural and the singular terminology. If we are just referring to one of them, for example, just this will be your right lateral fornix. Just this will be left lateral fornix. And I'll show you another model. Here you can, basically if I stick finger under the cervix, my fingers will rest or enter into the posterior fornix. Posterior fornix is basically what's behind this cervical protrusion. I'll show another model for that. Okay. We don't see an anterior fornix because the uterus typically is anti-flexed, meaning it's tilted in such a way that this edge touches the vagina on the anterior end. There is no arch. If the uterus is tilted backward, I wish I could show you the PowerPoint files that I have. Maybe we can, we'll see. I should have some time next class for the histology. So I would like to go over some things in the PowerPoint slide. So anyway, normally the uterus is anti-flexed. Keep that in mind. The normal position of the uterus is anti-flexed. When that positioning is off, the uterus tilts toward the back. It's called retroflexed. When the fundus is protruded to the back, we call it retroflex. Normally the fundus is leaning toward the front, anti-flexed. Okay. These fornices are important because, you know what, let me see if I can find one just for this part. Let's see. Oh, yes, we do. Okay, I have uploaded the pictures of, just the uterine tube. What? Bring it up. New share. This, yes, share. Huh? Share. Can you see the uterine tube?
Yeah.
Okay, gosh, thank you. Thank you, Lord, that I don't believe you. Okay, so you can see that. This is a nice one. You can see the clear fimbriae. You can see the infundibulum. You can see the ampulla. You can see the isthmus, ovary, suspensory ligament, ovarian ligament. Okay. So all of these pictures are uploaded into Canvas. Make sure you're looking at the different aspects of it. But I'm only using one to go over the demo, but I have also enlarged parts of each. So here there is the fornices. So let me bring this up. Bring it up. Okay, now this one is showing sperms in there for extra entertainment, I guess. All right, so here you can see cervical canal. See, that's the uterine isthmus. You draw a straight line through the uterine isthmus. Basically, this is the internal os. This is the external os. Here, the fornix. I want to use a different color for the fornices. Right there. See that arch, arch, arch. So these two are lateral fornix together, fornices. This is posterior, never mind, posterior fornix. Okay. Many of you will be working in hospital and you might have to do some rape detection. So I'll talk a little bit about fornices and their role in rape detection. So posterior fornix is basically, again, if I'm inserting this mouse, this line here, if you insert your finger, that's that space right there. That is posterior fornix. See that? If I insert there, right there. Oh gosh, yes, I have to use the draw again. Right, that space. Okay. Typically what happens that when a woman is when the intercourse is not consensual, both people did not give their consent, forced entry basically. When a woman is raped, two things happen. First of all, the woman would be fighting. Even if she's not in a position to fight, most of the time she's not lubricated because she did not give her consent to this. A non-lubricated vagina. If penetration was done to a non-lubricated vagina, then these vaginal walls here will show signs of trauma. Vaginal wall, and you can see the rugae also very clearly in this one. See the vaginal rugae. The vaginal walls will repair themselves pretty quickly, just like gastric wall, 2 days maximum, 48 hours, vaginal wall will repair itself, which is why the tissue sample from here should be taken within those 48 hours. Something else happens. In a normal sexual response where the woman gave her consent, so she's there willingly, her body is going through the average human sexual response, which goes through an arousal phase, a plateau phase, and then an orgasmic phase. In a forced entry, a woman's body is typically, unless she's unconscious, she's not going to go through plateau and orgasmic phase. What happens in plateau phase that this entire cervix, the uterus starts receding, starts lifting up. The cervix recedes, which then cuts off this posterior fornix. The idea is allow the entire space here and cut off this space here and allow the sperms, which they're showing here, allow the sperms to go straight into the cervical canal. The longer the sperms stay within the vagina or vaginal canal, the more likely they are, more susceptible they are to be killed. Vaginal pH is acidic, uterine pH is not. Vaginal environment is hostile to the sperms, uterine environment is not. That's why right after the semen is discharged, the semen coagulates. When the semen coagulates with the sperm, etc., this is what I said last class, that the sperms on the surface die out from the vaginal acidic pH. Then the semen liquefies. As soon as it liquefies, the sperms that were trapped inside that clot, they survived. They start swimming forward. Viable sperms always swim forward. And so in plateau phase, when the cervix is receding, it's making sure that the sperms have an easier access. They can quickly swim through enter through the external os into the cervical canal. In a rape, that won't happen. Plateau phase does not happen unless the woman is unconscious. Sometimes if the woman is unconscious, especially if she was drunk, under intoxication, any kind of drug, she was intoxicated, then oftentimes her body will go through the response with her being unconscious. If you just, if someone hits a woman over her head and knocks her unconscious, doesn't mean that her body is going to go through the response. But typically for an intoxicated and then unconscious woman, it's common for her body to go through the sexual response without her knowledge. Hence, all these date rape drugs, etc. Pathetic. I mean, we are pretty beastly. Anyway, so plateau phase doesn't happen unless in that specific case. So what happens? Basically, sperms will pull here and here and here. I'm going to erase all ink again. So all the sperms that you see here going into the cervical canal, they will go here. So in rape, for 48 hours, they will be pulling off semen in the posterior fornix, which you'll find sperms in there. In normal mutually consented sexual response, you won't find sperms in the posterior fornix. In rape, you will see damage to the lateral fornix and damage to the vaginal wall. In a mutually consented sexual intercourse, you won't see that. But all of these signs are basically going to go away in 48 hours, which is why it's imperative that someone shows up to the hospital saying that I have been raped, that the nurse takes a swab sample from the posterior fornix and another one from the lateral fornices and from the vaginal wall. You think that that's standard procedure. There's a rape kit that's provided to the hospital. That is standard procedure, but you will be surprised how many times that procedure is not followed. Okay. So, over the years, I have many stories that people share with me. Since I teach the 2-semester course, a lot of people share their personal lives and things with me. They feel comfortable, and I feel that that's good. That if people feel comfortable, sometimes I can help them. Other times I can direct them. Sometimes I can't help individuals. So some stories are horrendous, but some stories are also horrible stories. I ask permission of the students if I can share it. If I'm moved by it, I'll share that story. And I share it because there is some lesson to be learned and something that's not to be repeated. So I have one student a few years ago. Something happened to her. She was, she was gang raped basically by her roommates. Not roommate. I mean, she was from out of state, so she was staying with who she thought was her best friend. She was a short-statured woman, so not much of an alcohol resistance. So she drank some glasses of wine. It was someone's birthday party at her friend's place, but she was staying. It's a family. And so she was saying, my friend's mom said, you're in a safe place, just drink some. So she drank some and she did not even know. She said, I just passed out. All I remember are her eyes and breathing. And when she woke up, she realized she was raped. Later on, she knew that she was gang raped by her friend's brother and 5 of his friends. Anyway, she went to hospital in the 4 or 4:30 in the morning. That's what, if I remember right. And told the nurse that she was gang raped. What the nurse did, she treated her wounds. She had bite marks, wounds, bleeding, and told her that, oh, there is no way you can press charge now. So let me treat your wounds, you can go home. She was a young woman. So plus, no family. So I'm assuming that she just believed if the nurse is saying that emergency, she went home. And then a couple of years later, she's in my class and I'm telling her that this can be proved, but it has to be done in 48 hours. So she was very traumatized, angry. I tried to send her to counseling, sat with her for hours, trying to do whatever I can. And so I asked her, can I share your story so that every student from my class that ends up being in that situation, not to do what that nurse did. That is the goal of my sharing the story. And you would think that, no, that doesn't happen. I had a male student once. I'm just saying male to refer, nothing against male. So he actually got angry. He said, are you telling me, it was, I think, a year after this student that I had in my class. So I have been sharing her story since, every semester. So he said, are you telling me that the hospitals in San Diego do not follow protocols? And I said, well, yeah, according to her, that's what I'm telling you. And I had a second student in that class, and Sophia. Sophia had interesting experiences. She traveled, worked for WHO, and she worked as a paramedic. She worked as a nurse. She went to Africa, did some research work there. And then she was starting to be a physician's assistant, a very intelligent, level-headed person. So Sophia actually said, I have seen that happen. I have worked in hospital. I have been assistant to that nurse and have seen nurses say that. And one time, Sophia said, I even confronted someone that he said, you can't do that. Aren't you supposed to just take the rape kit and take her report and do the swipe and etc.? And the nurse said that, oh, that's a young woman. I mean, look at her, 4 o'clock, she probably asked for it and now she wants to blame her boyfriend and who knows what. Plus I'm tired, I don't want to have cops now. Because you have to report it to the police and etc. So don't do that, please. 48 hours, typically is the max. After 48 hours, the acidity itself will digest the sperms, so there's not enough evidence. The damage will be repaired typically in 48 hours, not enough evidence. But if the sample is taken in less than 48 hours after the response, not response, I would rather say the rape, then yes, you can collect evidence. It can be proved. Send the sample to the lab and you can see that if sign of trauma here, and not just seminal protein, but sperms in the posterior phonics. Okay, any question? I know it's traumatizing, and sometimes people feel offended. I even had a student who said, why are you sharing this? You don't know who has gone through what. I said, I'm sharing it so that who has gone through what doesn't happen. I'm trying to minimize that. It's a physiology class. People have cardiovascular disease. Does that mean I will not talk about cardiovascular disease, not to offend their feelings? No, we've got to get over that. Okay, so female pelvis. I want to show you for the genitalia, etc. Female pelvis right there. Yes, no, download it. I have to start a new share. Oof, gosh, this new share is so annoying. How much time do I have? Okay, I should have enough. Okay, so this is what I call a female pelvis. Just like we looked at the male pelvis model, this is the whole female pelvis. Okay. Let's look at whatever we can identify here. So there is the uterine tube, the fimbriae, the infundibulum, the ampulla. Okay. So here will be the ovary. This will be the suspensory ligament. That will make this what? If this is the ovary, That's the suspensory ligament. This area will be what?
The ovarian ligament.
Ovarian hilus. You don't see the ovarian ligament here because ovarian ligament are from the side. Well, actually, you do see. You see the ovarian ligament here. Beginning of the ovarian ligament. Because if I am to draw the ovary will be like this. To the ovarian ligament. So this is the floor of the abdominopelvic cavity. I'm going to erase these inks. So this is the floor of the abdominopelvic cavity. Okay, right here. So urinary bladder. This is the uterus. See how the fundus is facing anteriorly? See that? This is what we mean by antiflexed uterus. When this uterus faces tilted toward the back, that's when it will be retroflexed. If the fundus is tilted to the back. But this is the normal fundus, antiflexed. This ligament here that I'm tracing, see how that white layer covering the entire uterus and then extended over the bladder? This is what we refer to as broad ligament. This broad ligament is the main support of the uterus. The uterus also has something called uterosacral ligament and a round ligament, but those are pretty thin. This is the main support. This is what holds the uterus in place. That's why a retroflexed uterus is also more susceptible to what we call uterine prolapse, meaning the uterus starts descending. Okay. An antiflexed uterus does not. A retroflexed uterus is more likely to have uterine prolapse, where the uterus starts descending. Okay. What else we can see here? We can see part of the vulva now. Let's talk about the vulva. So by the way, this muscle layer right there, what I'm drawing. This is the female, what is it?
Perineum?
Muscle layer. From pubic symphysis to coccygeal bone, the skeletal muscle, what do we call that? We have gone over that for urinary system and we have gone over that for the male reproductive system.
The urogenital diaphragm?
Yes, female urogenital diaphragm. Okay. So perineum would be an area. So again, from here to here, an area. That's female perineum. All the structures that are accessible through the perineum, this and this and this, all of this, these are collectively referred to as vulva. Okay. So female perineum and vulva. I'm going to erase all ink. Let's look at what are the vulva here. So mons pubis. Mons pubis is a fatty cover over the pubic symphysis. So right there you have the pubic symphysis. This is mons pubis. Let me give it a different color. Mons pubis, right there. Okay. Between the thighs, basically in the perineum, you will find folds of skin which are keratinized and non-keratinized. So the outer fold of skin that's keratinized and with hair, This is what we refer to as labia majora when you are referring to both of them. This is a sagittal section. So you are only looking at the right side of it. FYI, that's called labium majus. But that term has become pretty much obsolete. Oftentimes now it's referred to as right labia majora and left labia majora. Technically it's labium majus, but I usually say you don't have to know that. That term is gone. Unless you are talking about, anatomy conference, nobody says that. Labia majora, right and left. So this is labia majora, see that? Within the labia majora, the fold of skin that's non-keratinized is labia minora. This labia minus individually, but again the same thing is called left and right labia minora. Now let's look at this with this part being removed. I apologize for my dog barking. Dogs are dogs, just can't control them. Let me see, where is that? Oh, right there. Shut up. Give me that. Okay, right there. Share. Share. Okay. So now we are looking at that top part being gone. You can see a lot in this female pelvis model. So labia majora. This is that and there. This is labia minora. Labia minus, technically, that. Now it is, they're called right and left labia minora. So make sure right and left, you are mentioning that. Then where the two labia minora meet, that's where you are going to find the glands of the clitoris, which is this. Glands of clitoris. Can you guys see this blue? It's not too clear. Come on, where is that? Glands of clitoris. So this here is glands of clitoris. Rest of the clitoris is this. I'm going to just use dotted line. See that? This is the body of the clitoris. Clitoris is erectile tissue. Same tissue as the penis. Corpus spongiosum. So body of clitoris, glands of clitoris. The fold of skin, let me use a different color. The fold of skin that's over the clitoris. See this fold of skin? That's the glands of clitoris. This is the fold of skin. That's not the labia minora. Labia minora starts here. This is what we call the, excuse me, prepuce. What else can we see here? We see the vaginal orifice. You can see this hymen. Hymen is basically a ring with added fold of skin, little thicker fold of skin. So it's said that if the hymen is intact, then at the first penetration, that fold of skin will rupture and there will be some bleeding. Okay. However, in modern life, hymen is not just ruptured by penetration, it also ruptured by horseback riding, gymnastics, playing soccer, acrobatics, or just plain running and falling at a wrong angle. So a lot of women these days don't have an intact hymen, whether they are sexually active or not. So this obsession with an intact hymen, again, certain religious groups say that demand that even educated people demand that on your nuptial night, wedding night, there will be a white piece of cloth. Even these days, I have a biotechnologist friend who had gone through that. A piece of white cloth under their buttock so that the blood can be caught there, and so the spotting or the sign that proof that she was actually bleeding will have to be shown to the bridegroom's family next day. If not, then oh well, nowadays you can't really banish, but there will be pretty much bad name and reputation following that woman. I asked my biotechnologist friend that, being a biotechnologist, you actually allowed that? It's like, well, yeah, it's my culture. Just because something is culture doesn't mean it should be accepted. Sure, slavery was culture at some point. Being educated, we should all be able to make our judgment of what is acceptable, what's not, and at least protest. Be aware and use your sense of better judgment. Not everything in the name of culture is good. Some things are good, they should be kept. Some things are bad practices, they should be gone, they should be extinct. And again, the whole thing biologically, hymen can be ruptured by so many other things. So this obsession with hymen is totally not founded in biology. Even I think Princess Diana had to go through that testing, virginity testing, whether her hymen was intact or not. Unbelievable. Anyway, so that's the hymen that shows here. You can see the vagina. You can see the posterior fornix here. You can see the external os. See that? You can see the internal os. You can see a lot of structures of the uterus. So external os, internal os. You can see this is the cervical canal. You can see the uterine isthmus. See how it's constricted here? It's just a sagittal version instead of frontal version. Uterine isthmus. You can see the endometrium. That's the endometrium. The myometrium, all of that muscle. You can see the perimetrium, this. You can see the uterine fundus, uterine body, uterine isthmus, and cervix. You can also see the internal urethral sphincter. Then this is the urogenital diaphragm. So you can see the external urethral sphincter, urethral orifice. So there's quite a bit here that you can see. Mons pubis. Almost all of the vulva can be seen here. What you don't see is the bulb of vestibule and greater vestibular gland. So I'll show you those in a second. Any question about this?
For the posterior fornix, can you see the lateral fornixes too?
No, because this is sagittal section, the lateral fornix is hidden.
Okay.
Just like in the frontal section, you could not see the posterior fornix or anterior fornix. Not much of anterior fornix because it's antiflexed uterus. You can't see the lateral fornix in the sagittal section.
Thank you.
Okay. So let me show you the greater vestibular gland and bulb of vestibule. For that, you have to, again, just this part here. So what we were looking at before, I lifted that part, and I'm also showing some of the interior part. Okay. So right there. So what you are seeing here, this is the labia minora. That's the left labia minora. This is the right labia minora. Technically labia minus. Bulb of vestibule. Basically, this is the labia minora. Between the majora and minora, the fold of skin has erectile tissue, kind of like how the corpora cavernosa is. The same kind of erectile tissue. This is what gets engorged in sexual intercourse, and this is what makes the withdrawal of the penis somewhat difficult and painful. So when the penis is also engorged, this is also engorged, it makes the withdrawal difficult until the penis, basically the man ejaculates and the penis deflates. So the whole idea from biological perspective is again that, you know, an entry of the penis should result in ejaculation, because that's for reproduction. That's what would deliver the sperms. So this is what we call the bulb of, what I'm going to read is this. I'm going to change the ink color. Bulb of vestibule. Okay. So this shows us, and the greater vestibular gland is this. That secretes a special type of mucus. You can also see the urogenital diaphragm. Okay. There's also an inside of this, or you can also see the clitoris right here. You can see the glands of clitoris. So the interior of this, which also shows the uterine and bladder section. Any question about this? So you can see the labia majora, labia minora, what we just went over. So make sure that you are, I want to bring up some other things here. Make sure that you are looking at actually, I went over that. See, this is just that part. I went over the structures, but make sure that you're looking at this separately as well. You can see the bulb of vestibule, labia minora, urogenital diaphragm, broad ligament, you know, everything that we went over. This is just the piece on top of the model. I would like to show a different uterine model that shows the fornices very clearly. So looking at the pictures here. Where is that uterine model? Oh, right there. So 2670, 2669. See, this is what I share. Download complete. Okay, fine. Okay, so this is what I call, you can see the tiny uterus, right? That I'm holding in my hand. Well, I was holding when we took the picture. So I call this Dumbo because it looks like Dumbo's ear and Dumbo's trunk. So anyway, this is just a tiny uterus model that we have. Uterine tube, ovary, and uterus. You can see the uterine fundus, uterine body, uterine isthmus, and then cervix is not very clear. But on section, when this is removed from this, that's when you can see the fornices. So this one, especially I like it for the fornices. Can I just share the fornices, please? Okay, right here. So basically I separated both. And here you can see the posterior fornix. You can see the lateral fornix. You can kind of see the anterior fornix too. And see the vaginal rugae, the vaginal canal, and the vaginal rugae at these folds. This model is especially nice for the fornix. And you can see the pose too. Okay, got that. Okay, so then I want to show you a different version of pelvis. That is the standing female pelvis. Oh, right there. We have looked at that, but something else I wanted to show you here. Forgetting what, oh yes, the uterine ligaments. There's a different model. Right there. Bring it up. It's not even giving me the option of new share. Okay, see that? You guys can see a different model here. This is the same structures as what we studied for that other uterus and uterine tube model. This one just shows the ligaments along with the uterus and uterine tube. So what you are seeing here, this here, that is the broad ligament. To have something darker. So this is the broad ligament. So is this. You can see this is the ovarian ligament. Here is the, here and here is the suspensory ligament. That means right there is the ovarian hilus. This is also ovarian ligament. You can see the fimbriae, infundibulum, ampulla, isthmus. Same here. You can see the No, don't give me that. Let me see if I can move this down a little bit. So same thing here, Fimbriae. No. Go to hell. Sorry. Disappear, please. If I do cancel, what happens? Should we even try to find out? Okay.
Guess not.
Guess not. Yes. Fimbriae. Isthmus. Constricted. Ampulla. Actually, gosh, stop it. Oh, I can't believe I'll be doing this in fall again. Looks like we'll have fall online as well. So anyway, you'll be able to see this fimbriae right there. I want to show the infundibula. This darn control is not letting me do that. Okay, anyway, I did that here. You can see the uterine fundus, uterine body, uterine isthmus, cervix, cervical canal, internal os, external os, uterine cavity, myometrium, perimetrium, and well, endometrium, you can kind of see that. It's kind of purplish, see that? Endometrium. Perimetrium, you don't really see that. So make sure that you identify whatever you can identify from here. You can see the lateral fornix here too. Question?
I had a couple of questions looking through the list in the lab manual. Can you see on any of these models, I have the secondary oocyte, the follicular.
You can. Yeah.
Follicular
Antrum,
and,
follicular antrum, yes, okay.
And is it fecal cell? Fecal?
Thecal cells and granulosa cell. Thecal and granulosa cells, they are really for histology, but you can see them in the ovary model too. So you'd be able to, before I move on to that, you'd be able to identify the female urethra from this model, whatever you can, because we went over this. Bring it up. You're not even giving me that new share. I guess I've done too many shares already. See that? We went over this. So you'll be able to look at the, internal urethral sphincter, female urethra, external urethral sphincter, labia minora. You can see that here, labia minora. Little bit of the labia majora. This would be the perineum, female perineum, not just perineum, female perineum. It is. I think you should be able to study that. The vaginal orifice, the vagina. So to show you the thecal cell, granulosa cells, and the follicular antrum and secondary oocyte. Let me go over to the ovary model. Where do I? Yeah, those are mostly for histology, but let me show you here as well. I can show that on the Graphene follicle and on the secondary follicle. New share. Oh, not just letting me do the new share. How about that? Life is good. Okay, so we are back to this Graphene follicle. This space within the Graphene follicle is follicular antrum. Okay. This, let me use a different color. Where is the color control? Pink. Pink is good. This row of cells right there, see all around? These are what we refer to as thecal cells. along the edge of not only Graphene follicle, but secondary follicle too. Thecal cell and granulosa cells are two rows of cells that develop in a secondary follicle. In a primary follicle, remember I was saying you only see a single row of cell here. In a secondary follicle, you see one row here and one, oh, it's not letting me do that again, and another row there. Granulosa cells are the cells that are clustered several rows around the oocyte. So this is the oocyte. These are the granulosa cells. These are discharged along with the oocyte at the time of ovulation. The thecal cells, which are the cells along the edge, they remain in the corpus luteum and continue to produce progesterone. Follicular antrum is a space that separates the oocyte from the border of the follicle, and it develops from secondary follicle onward. So here you can see a little bit of that in this secondary follicle. So this is secondary follicle. It won't let me do anything because I have that control over there. So let me see if I can draw. Can I draw here, please? Nope. And you don't see the mouse. Do you see the light purple color that I'm making here?
Yes.
Can you guys see that? Okay, that's the follicular antrum. Notice it's between two rows of the cells that I leveled with white arrow. You see that? Two rows of cells that are leveled with white arrows and the purple in between. Basically that purple space, that is the antrum, follicular antrum that's just beginning to form. It's a very early secondary follicle. We'll be able to see this much nicer in the histology. But this is for reference. So what happens that primary follicles, which have only a single row of cells, oh no, it's not giving me color. Give me color. So primary follicle, which has a single row of cell, once a primary follicle becomes a secondary follicle, basically what it has, the follicle, the oocyte, one row of cell along the oocyte, one row of cell along the edge, and the space in between is the antrum, follicular antrum. This is a very early secondary. Then this row of cell, a single row of cell around the oocyte, this is what we call the granulosa cell. This row of cell along the edge, this is the thecal cell. This will be the granulosa cell. This cell starts secreting estrogen and progesterone. As the estrogen and progesterone deposits into the antrum becomes larger and larger, and the rows of cells themselves become multiple rows. So eventually this, which is a very early secondary, will become a late secondary, which is much larger with multiple row of cell around oocyte, with multiple rows of cells around the oocyte and a space between the two. So we'll be able to see this in histology next week. So a single row of thecal cells here. What I drew here with the purple, a single row of thecal cell here becomes multiple row of thecal cells. And the antrum is right there, follicular antrum. These are the granulosa cells. These are the thecal cells. Several rows of granulosa cells, multiple rows of thecal cells, and the follicular antrum just keeps enlarging because more and more estrogen, progesterone deposits in there. Ultimately, these fluids, which is antral fluid, will push the oocyte to an edge. And that's what we're seeing here. the granulosa cell, and the oocyte has been pushed to an edge, and the antrum is filled with fluid, and the thecal cells are along the edge. This also makes it easier for the secondary oocyte and granulosa cells, this whole thing is ovulated, to rupture and exit. So follicular antrum, granulosa cells, thecal cells. We will be again, next week, we'll be able to see them in histology, much clearer and better. But here you can see them. Any other question? Okay, so let me end the recording here. I'll upload this file and yesterday's lecture file. I need to do that too. Are there general associated any questions for the class? If there's anyone has question, then I'll log back in at 1 o'clock and we'll hold office hours from 1 to 2. 2 to 3:15 or 2 to 3:30 is what I have given to the 144 students. But last time only one student showed up. I have a feeling that only one will show up this time too, if at all. So if you do have questions, feel free to log in. There is also a waiting room for the office hours. It's the same link as this class link. And if I am talking to a student and if there are things that, that are not to be discussed with anyone in presence of another person, I would just send a text to the chat saying that give me a few minutes. In that case, just hang around or come back 5 minutes later. Does that sound like a plan?
Yes, Professor.
Okay, so then I'll log back in at, actually, you know what? Let me make that 1:15. I need to rest a little, to be honest. I'll log back in at 1:15, but your office hours won't end at 2. So I'll log in 1:15 and I'll stay there at least until 3:15 or 3:30. If no one shows up by, let's say, 2:30 or so, then I'll probably just walk away and come back. I'll leave the meeting on. So if some of you, let's say you log in at 2:35 and no one is there, that means nobody was there from 1:15. So I just walked away. I'll periodically check. So if you have questions, don't wait for until later. If you don't have a class and you do have question, log back in by 1:30. Does that make sense? Yes? So I'll stay glued to the computer for the first hour. After that, I'll start walking away and come back and check in. Typically, those that show up for the office hours, they show up toward the beginning. But the meeting will be on. So if you are able to get into the waiting room, stay logged in, unless your data plan is getting sucked into that. Then log out, come back in. As long as the meeting is on, meaning I am there, I'm just not looking at the screen. I'm walking away and back and forth. And I'll do that after the first hour. If nobody shows up for the first hour, I'll get up, walk for a couple of minutes, come back, check. If no one is there, I'll wait for 5 minutes, I'll go back, walk around and come back. It's just hard to look at the screen. All right, so I'm going to stop the share here. All of that got recorded. Jeez.